Hello. How's it going? That sounds really weird to me. It's okay, though. We'll persevere. So, thank you very much for the invitation. I really appreciate it. There's people in the room that know just as much about this topic as I do, so feel free to jump in as necessary. And so, I'm going to present a bunch of data to you. I'm going to talk a little bit about some of the programs that we've implemented at the state and the public health Department of Public Health level that I think are based on some of the data. And as I talk about the work that my office does and some of the partners that I have across the state, hopefully that will become clear. It sounds like questions. Should we hold questions? Or can people throw questions out as we go if they have them? I prefer that if you have a question, throw them out. So if you have a question, let me know. I have a series of slides, but if we have to move away from them a little bit, I'm happy to do that as well. Here's all my contact information. Absolutely, as I'll show you, the budget for my office is very, very small. So we often have to partner with universities and students who want to do projects and help us out with some of a mutually beneficial relationship with helping us out with projects and helping folks towards their degrees, whether it's a capstone or graduate degree or PhD or whatever it may be. So, yeah, thank you for mentioning that because I absolutely welcome those conversations. And so, I'm a state schlep, state bureaucrat, which is a hard place to be at. Hopefully a lot of what we do and a lot of what I really put emphasis on is how do we work better in the community and partner with organizations to do this really important and quite frankly really hard work. And so this isn't just about the work that's done at the state level. A lot of the data that I'm going to present is housed at the state level, but how we apply it goes well beyond state bureaucracy for sure. So if everybody's cool with that, we'll just dive in. Okay, right on. Other than a few of you who I know I've presented to before, have you seen this painting? Great. So this is a painting called The Lovers by an early 20th century surrealist Belgian painter by the name of Rene Magritte. I am so not an art connoisseur. But I encountered this painting on a trip to New York City about 10 years ago. A buddy of mine who I traveled with, he's an architect by trade and he's a photographer by hobby. So while we were there, he reluctantly drugged myself and another buddy to a couple of museums. And when we were at the Museum of Modern Art, they had a room with Magritte originals. And so I was totally drawn to this painting. And I still don't totally know why. I think because of the mystery of it. It's really rich in its color. But it struck me enough that I remembered I took note of the artist and the title of the painting. And when I got back to Colorado, I did a quick Google search, and it turns out that when Magritte was 14 years old, his mom died by suicide. And when they pulled her out of the water, her nightgown was wrapped around her face. And so I was totally blown away by that because I just started doing work in suicide prevention. I'm not an art guy, but I was drawn to this painting that had this direct kind of relationship to the work that I had just begun doing. And so I've been using it to introduce this topic of suicide and suicide prevention ever since because I think it introduces the topic really well. And as we dive into data, we can talk about it. But part of it for me is this notion that suicide is faceless. Faceless in that it doesn't discriminate regardless of one's age, race, sex, sexual preference, socioeconomic status. Everyone is impacted by suicide at some level. And it's faceless on the other side that it's not just readily apparent when someone is suicidal, like it is with other illnesses sometimes. And so that's really relevant to me. Another thing that I think is important is that Magritte painted The Lovers when he was 28 years old, and so it was, 15, 16 years after his mother died. And when we talk about suicide, I would argue that the complexity of surviving a loved one's suicide, that it's a manner and cause of death that brings with it some issues that aren't necessarily always issues when we talk about other types of death because of the stigma that is involved. Because people who are left behind are left to grapple with things like guilt, blame from other people, and equally important, this notion of never being able to answer the question of why. And so that's really complicated for people who are left behind by suicide, and in turn, it oftentimes will put people themselves at risk for suicide. And so it's an important factor when we talk about suicide prevention is that you also have to think about the folks that are left behind. And then the other thing that I think is really great is, and this occurred to me because someone told me after I presented this painting, a woman came up to me after a presentation. She said, when you showed that painting, it made me uncomfortable. She said, I immediately thought of terrorism, and just it's kind of a haunting image. And I said, that's perfect, because this is absolutely a topic that people are not comfortable talking about. It's one of those things that historically we've identified as a personal, private, individual matter that it's not our jobs to meddle in. And so all of that has to be thought about and considered when we talk about how to do suicide prevention and how we relate data to folks and things of that nature. And so, again, I've been using this painting for a long time, and I think it just helps introduce the topic pretty well. Yes, sir?
What was the artist's last name?
Yeah, the artist's last name is Magritte. It's Magritte. And the painting's called The Lovers. You should buy me a print, because I'd love to hang at my house. Scare my kids. So it's also important when we talk about stigma to talk about some of the attitudes that people bring to this topic, because it contributes and speaks to how we should do prevention work. This historical notion that suicide's a sin. Every major religion in the world views suicide in a negative light, and rightly so, because it's a topic that we don't want people to die by suicide. Unfortunately, historically, we focused on the sin and the sinner rather than the issues that create the suicidal thoughts or the suicidal behavior. And in the unfortunate incident when somebody dies, we focus on the person who has died and not the people who are left behind, and making sure that they have the resources that they need. And the reality is, with limited resources, the faith-based community is one of the partners that we have to rely on to get people the support and the help that they need when they're suicidal or when they're a family member of someone who has died by suicide. And so this is one of the things we encounter pretty regularly. This notion of weakness. That people who are suicidal or who have mental illnesses or who die by suicide simply just can't bootstrap their way through their problems like you and I can. That's something I'll argue with you about as much as you want to. We can do that afterwards. You can buy me a beer and we can have a nice debate. But it's this thing that we push back against, because if there's a social belief that speaks to this notion of weakness, then it pushes people away from asking for help or from us offering them assistance, because we just hope that they'll get through it on their own and that they'll figure it out. That's a challenging thing to do if one has a brain disorder. And then this notion, which I call the apathy attitude, right? I can't be with somebody 24/7. If somebody's suicidal today and I intervene, that's great, but they'll just kill themselves tomorrow. This attitude, to me, speaks to the misinformation about how suicidal crises usually proceed. They're usually short-term, they're usually pretty acute, and if you can keep somebody safe during that short amount of time, the likelihood is that they're going to live, not that they're going to die. And so this, when we're doing public education and awareness, is really about giving people the tools to intervene when necessary, and providing people who may be feeling suicidal with information about the fact that this doesn't have to be an all-the-time affliction. Okay, so very briefly about my office. Hopefully very briefly, because it's boring, But there was a charge to serve as the lead entity for statewide suicide prevention and intervention efforts. I am currently a 2 full-time employee office. I'm one of those employees. The other employee is distributed across all types of other people. So really, it's me in trying to fill this charge. And so this is an impossible task. So where I mentioned earlier the need to collaborate with people doing this great work across the state is critically important. But here are just some of the activities. And I'll talk about a couple of these later in the presentation. Part of what I do is give out small community grants every year to people at the local level doing suicide prevention work to help them do their work. We fund currently the National Suicide Prevention Lifeline, which is that 1-800 number. So if you call that number from anywhere in the United States, it will be routed to a call center that has trained people who can respond to suicidal crises 24/7. In Colorado, currently there are 2 crisis centers. One's in Pueblo and one's in Denver. And in Denver, it's Metro Crisis Services. So they are open and available 24/7 to help folks or families who are experiencing a suicidal crisis, or to provide information about suicide prevention in general. What created my office took place in the 2000 legislative session, which basically is what I just said, created the charge for me. You'll note the budget. The original budget was about $157,000. My current year budget is just under $400,000 with this charge of doing suicide prevention for everybody in Colorado, all ages of Coloradans. So, again, not a simple task. However, we are in a pretty unique place in Colorado in that we're one of 4 states currently that actually has a set amount of dollars set aside specifically for suicide prevention and intervention. So most other states do some level of suicide prevention and intervention work, but it's not specifically set aside for suicide prevention and intervention. And so it puts us in a pretty cool position to have sustained projects and funding and staff, where at the same time we're set up to apply for federal grants, to partner with universities and other organizations to try to do this work on a consistent and sustainable level. And so finally, one recent bit of a model or a theory of suicide. If you're interested in the topic of suicide prevention and you want to read a really great, easy-to-read book, I recommend Why People Die by Suicide by Dr. Thomas Joyner. And his theory is a pretty simple one, but it's a pretty fascinating one. And basically his argument is that on the circle on the left, that all of us at points in time in our life experience these notions of perceived burdensomeness and thwarted belongingness. What Joyner argues is that when one becomes most acutely suicidal, at highest risk for suicide death, is when you couple those two with what he calls the acquired capacity for suicide. So this habituation of suicidal behavior or thoughts. And so examples of people who fit into that category for Joyner are people who, like law enforcement, people who are in the military. They are people who, when they become suicidal and have access to and knowledge of how to use the lethal means by which they attempt suicide, it puts them at an elevated risk for suicide death. Other examples he gives that are pretty fascinating in his book include people who have anorexia. That what he argues is that self-starving process is an incredibly painful one, and he's looked at the research, and basically this is a bit morbid, but what it essentially shows is that people who are anorexic and die by suicide by some of the most lethal means that they've come across in the research. And so it's a model that he brings a lot of examples to. And as we look at the data, it'll kind of become apparent as we look at the patterns and the trends and who dies by suicide, who survives suicide attempts. He uses that data to fit into this model. Okay, so let's jump into the data a little bit. These are data from the U.S. from the CDC from 2008 to 2010. I'm going to point your attention to the states, whatever that is, burnt orange. Those are the states in the U.S. that have the highest suicide rates. And when you look at this top 10 on the right, you see that Colorado fits in there. We are always in the top 10 for suicide death rates. And what's really interesting is this pattern of where the top 10 suicide states lie. They're all, for the most part, in the Rocky Mountain West. And so there's a variety of theories that try to explain why that is. This is definitely an area of opportunity for research to help explain these theories better. But some of the predominant theories include that in the western U.S., we have vast rural and frontier geography. And what that may mean is that people have much more limited access to available mental health services. There's also this notion that in rural communities, even if there is a mental health center, that people won't access those services because everybody knows everybody's business in a rural community, and if there's stigma around accessing those services, then you're not going to go park your car out in front of the mental health center. There's also this notion that in the western U.S. and in Colorado, I would certainly argue that we still really embrace that rugged individualism mentality, where the notion is if you're suffering, particularly if you're suffering from an emotional issue, you pick yourself up by your bootstraps and you take care of your problems on your own. So that, again, keeps people from accessing available services. So you compile that with also the fact that we have these vast mental health professional shortage areas, and people are resistant to accessing those services. it creates a space where people aren't getting the help that they need. So there's some really cool research around altitude and suicide that needs to be tested. It's pretty controversial, but that's happened in the last 5 years. In the last 10 years or so, there's research around states that have the highest in-home firearm ownership rates. Those states also have the highest suicide rates. Colorado's interesting because we're not in the top third for firearm in-home ownership rates, but all the other states in our little corridor here are. And then, of course, there's states like Texas and Georgia who have low suicide rates, but, of course, considerable home firearm ownership rates. So, again, those are just some of the theories around why that might be. So when we look specifically at Colorado and try to frame suicide as a public health problem, here are just some manners and causes of death in 2012 and the numbers of deaths in those particular manners and causes of deaths. Note the 205 homicides. Note the 457 people who died in their cars in Colorado in 2012. We had 1,053 Coloradans die by suicide in 2012 in Colorado. Surprising to anybody? Maybe? Excellent. So people typically are surprised by these numbers because we don't see the suicide deaths on the news. We don't hear about them. I would venture to guess that every single one of those 205 homicides were covered at some level by the media in Colorado. So we are on edge about those. And also, things like mass shootings, which is very real in Colorado. The emphasis is put on homicides, and the thought about Colorado, particularly with motor vehicle deaths, is that lots of people die in their cars, which again, these numbers aren't good, but when you look at suicide, there are far more suicides every year than there are homicides or motor vehicle crash-related deaths. And unfortunately, 2012 was our highest year and number of suicide deaths that we've ever had in Colorado. And when we look at public health approaches to how to do good public health work, the motor vehicle folks are an example of doing really awesome public health work. And what we are seeing are reductions in our motor vehicle crash deaths. And they're doing it across the spectrum, right? There are laws. We all know what click it or ticket means. There are car seat laws. I'm sure sometime in the near future we're going to have the, what do they call it? The primary seatbelt laws. There are drunk driving laws. We have the technology, right? Cars are just made better and safer now. We have the education and awareness. People understand, and there's this social norming change around wearing your seatbelt, following the laws, don't drink and drive because we know the consequences are severe. And so I think it's just a model for us in suicide prevention, along with other things like tobacco prevention and other things that have shown some success that we can use in suicide prevention to hopefully advance our unpleasant upward trend. For all ages, suicide is the 7th leading cause of death in Colorado. And for those ages 10 to 24, suicide is the leading cause of death. Before this year, I've changed my stance. I'm curious to know what others in the room think about this. We've always lumped unintentional injuries together as a cause of death when we look at the data. So historically, unintentional injuries includes motor vehicle crashes, fall deaths, drowning deaths, things like that. They're all together. Suicide was the second leading cause of death for this age group. But when you separate falls, motor vehicle, drowning out, suicide is the leading cause of death for that age group. And so I've kind of just reframed how I approach that, and I'm sure maybe my epidemiology friends in the room and at the state health department may disagree with me on that, but we can argue that over a beer too. So the data sources that I'm going to talk about today beyond whiskers are the Colorado Health Information Data Set, which is basically the death certificate data, which is all housed at the state health department. Those data are looked at by county of residence of the decedent. So when we look at the county level data, it's where the person resided at the time of death. So oftentimes at the local level, coroners will have different numbers for their county than the state health department will. Because, for example, in Garfield County, if someone lives in Garfield County and dies in Mesa County, the Mesa County coroner will investigate that death, but when we put it into our data system, that's a Garfield County death. So sometimes there's small discrepancies. So what you can see from the Colorado Health Information Data Source is that we are on an upward trend, unfortunately, in Colorado over the last 5 years. I assume that this could be directed towards the economic crisis. Yeah, go ahead. So the question's about if someone outside of Colorado dies in Colorado, how does that death get counted? Yeah. So the military is a good example of that, and it's a complicator in our data because we look at county of residence. So if somebody from Kansas dies in Colorado, that's not counted in this data set in either of these that I'm going to talk about today.
But if somebody who's living on a military base,
if that's their permanent residence, yeah, and so I think that's, and I'm not an expert on that, but if it's just a temporary residence and their permanent residence in Georgia, it won't show up in our data. It'll show up in the military data. Yeah. College kids is a good example. Yeah, that's right. That's correct. Yeah. Did you have another? Okay. Yeah. Perfect. So yeah, thank you for the questions. And so let me just, before I forget, the other data source that I'm going to present today is the Colorado Violent Death Reporting System data source, which is part of the National Violent Death Reporting Data System, which is a CDC reporting system. Colorado is one of 18 states that participates in that data system. The CDC, and it was actually I think in Obama's budget last year, is to try to expand that data source to all 50 states. We have data in the Violent Death Reporting System since 2004. What it allows us to do is look at the circumstances in a person's life prior to death. So it gives us much more information in detail about a person's death than we've ever had before, because prior to 2004, we only knew what was on the death certificate at the statewide level. This allows us to look at the narratives from the coroner's report and from law enforcement reports and give us a sense of what was going on in a person's life prior to death. And so examples of what we can glean from that data source are things like job problems, legal problems, current mental health treatment, things like intimate partner problems, all kinds of things that we can look at, which helps us from a public health standpoint prioritize and devise prevention strategies. And I'll provide an example of that in a little bit. Okay, so anyway, let me just address the age-adjusted rate here. That 2012 rate is the highest rate that we've ever seen in Colorado since we started calculating rates, but it's not statistically significantly higher than a couple of years in the mid-80s. So we had a couple of years in the mid-80s where we had rates around 19.4, 19.3, but since the mid-80s, it's certainly the highest rate that we've had in Colorado in a very long time. So there's this upward trend that we would argue is probably somehow tied to the economy. We know that when unemployment rates go up, that the suicide rate goes up with it. I was surprised by the 2012 data because I, in my mind, had this notion that we were in recovery mode from the economic crisis. So it'll be interesting to see how our rates progress in 2013 and 14, et cetera. Unfortunately, so the 2013 data will probably come out in August or September of 2014. So the data are a little behind, but it's what we have to work with. So a bunch of these next slides are from the Colorado Violent Death Reporting System database. And those, let me specify, well, I'm trying to confuse things here, which is not my intent. These are Colorado residents who died in Colorado. So there's no outside deaths in this data set. So when you break it down by age, what we immediately see, and these are just raw numbers, not rates, is that the burden for suicide deaths is very much carried by males, and our deaths are predominantly in that working age group, ages 25 to 64, the majority of the numbers of deaths. I would also argue that the vast majority of the funding that is dedicated in Colorado and nationally to suicide prevention efforts happens at the adolescent stage, so ages 10 to 24. which is an important demographic to target our efforts towards. But if my job and the people that I work with job is to try to reduce the suicide rate in Colorado, we sure better be doing some work with the working age population. And when we look at rates, we sure better be doing some work with older adults as well. And so it's that complicator of where do you focus your prevention efforts and your prevention dollars to have the biggest impact on the overall suicide rate. And historically, very little work has been done, particularly directed at the working age male.
If you get a little more granular, and actually you can do this yourself. You can go query this data set.
You can.
And if you break out the 15 to 24, the bulk of that is really in the 20 to 24.
Yeah.
It's not in the 15 to 19.
That's right.
And yet, a lot of our efforts have been directed at schools and really groups that you would think of as lower risk just by the data. Yeah, that's absolutely right. And the 0 to 14 is really 10 to 14 because we don't report data younger than 10. And so when you look at the rates, it matches pretty similarly to what the numbers show. Those ages, and these age groups I know are bigger than the last slide, but ages 45 to 64 across the board since 2008 have the highest rate of suicide deaths, and this is both sexes here. And so to Michael's point, when you look at ages 10 to 17 across the board have considerably lower rates than all of the other age groups. And as you go higher, the rates just go higher as well. Prior to 2008, so if we looked at, say, 2000 to 2007, the highest rates we would see among older adults. So there's been a little bit of a shift in the age group that carries the burden in the suicide rates to more of the working age group than the older adult age group. Historically, adults ages 85 and older adult males 85 and older have the highest suicide rate of any age or sex group. When we talk about race and ethnicity, the burden is very much in Colorado carried by our white non-Hispanic population. Obviously, this is a state that is predominantly white non-Hispanic. From the 2000 census data, the discrepancy is, so the white non-Hispanics is about 80 to 84% of all suicide deaths. Our white non-Hispanic rate in Colorado is not that high. And our Hispanic rate, so the white Hispanic rate suicide death rate is lower than our population numbers in that race ethnicity group. Does that make sense? I don't know if I explained that well or not. Across the board, everything else pretty well matches our demographic numbers. So the method question of males versus females and dying by suicide. One of the explanations for why males carry the burden for suicide death is because they are much more likely to use the most lethal means in their suicide attempts. So firearms, of course, are the most lethal, followed by hanging. And when you look at females, obviously females use firearms as well, but females are more likely to use poisoning in their suicide attempts, which is much less lethal. So some of our efforts now are focused around this notion of means restriction, education, and awareness, which I'll talk about in a little bit. And then by age group, the methods change as well. As you go up the age group spectrum, people are more likely to use more lethal means. And firearms, pretty much across the board, except for our youngest populations, is the leading method in suicide deaths. All right. Excuse me. So I wanted to get this picture of the state as we were planning this convening meeting for Colorado. And so I worked with the Colorado Violent Death Reporting System folks to get a sense for the state of, because what we were trying to narrow down is, can we focus on certain parts of the state with our prevention efforts that kind of carry the burden for suicide. And so I give you just the demographic breakdown slide to get a sense of where everybody lives, basically, in Colorado. So our urban areas and how it's defined by the Office of Management and Budget. The urban areas are all of the traditionally defined urban counties, plus
counties where I think they said 25% or more of the workers who live in that county commute to one of the urban centers. So that's why places like Park, Clear Creek, and Gilpin counties show up as urban counties. It's because 25% of those residents or more drive to Denver or Boulder or wherever for work. And so that's why they're classified as urban counties. And then they break down rural between rural and frontier. And frontier is defined as counties that have per square mile 6 or fewer people in those counties. So very, very rural and very remote. And so this next slide is broken down by these health statistics region. Essentially, all of the traditional urban counties are their own health stat region. And then all of the rural and frontier counties are lumped into larger county regions. And so what this shows you, the dark orange counties, oh yeah, you can see it pretty well up there, with the diagonal lines, those are the counties that have statistically significantly higher than the state average rates of suicide deaths. And then, so Weld County, for example, and there's only a couple of those, Weld and Douglas County, are those counties that have statistically lower suicide rates than the state rate. And then everything else kind of falls in the middle. And so again, this is from 2008 to 2012. So it's an interesting way to look at where the highest rates of suicide are and where we potentially maybe should target some of our prevention efforts. And so this is just another way of looking at those regions. So the highest regions are in Northwest Colorado, Region 11, and then Mesa County, and then the Park, Region 17, Park, Teller, Gilpin, and Clear Creek counties are, when you look at this slide, the three that have those highest suicide rates during that time frame, which suggests that we should be doing some prevention work at those levels. But, and this, I apologize, these dates are slightly off because I didn't get some of these slides updated with my health stats team. When you look at the raw numbers of suicide deaths by region in a similar time period, there's a slightly different picture. So Region 11, that's one of our highest suicide rate regions, in that 5-year time frame had less than 60 deaths in the whole region. But their suicide rate is statistically significantly higher than the rest of the state. So let's just break that down a little bit further and look at Jackson County. I grew up in Larimer County, so I'm familiar, I had to drive through Jackson County to get to Steamboat every year. Big county. Not very big population. Walden is the biggest town in Jackson County with 608 people. I had to do a 20-year run of the data to get a rate because there were so few deaths. So in Jackson County, which is just one county in that larger region, there were 7 total suicide deaths in Jackson County in that 20-year time frame. But when you calculate the rate, it's higher than the state rate. And so from a public health perspective, let me show you the next slide. Larimer County, right next door, in the lower quartile of counties, really big geographically, very large populace. Fort Collins has 144,000 people living in the city of Fort Collins. In that same 20-year time frame, their suicide rate was lower than the state suicide rate, but they had almost 800 suicide deaths. So it creates this debate around how do we use our prevention dollars, because Jackson County, there's a need there, and I'm not saying you don't do prevention efforts in Jackson County, but is it more important than Larimer County or than Weld County that had, statistically significantly lower suicide rates, but had 163 deaths? Or Adams County, where I live, which again is low, but there were 323 deaths. And so it's just from the public health perspective and how we distribute very limited dollars and very limited human resources, what's the best approach to doing the prevention work? And I don't have the answer to that. We're trying to figure it out at this point, but it's very much worth considering. I'd argue historically in suicide prevention, our approach is everyone should be trained. Our job is to educate the masses and to prevent suicide across the state. That would be lovely if I had a budget that was 500 times as large as my current budget is. So it just speaks to the need to be more targeted. And so we also kept it in the health statistics regions to look with a little bit more specificity. And here are just a couple of examples of some of the data points that we looked at. And so by the distribution of the health stats regions, sorry for bouncing around here. So the low quartile, the high quartile, and the mid quartile is how I'm looking at these slides going forward. And so when we look at age, there's no difference between those three groupings. Males account for the highest. Did I do that? I'm sorry. I was thinking gender. I was on the next slide already. For age, so in those high quartile regions, those 25 and above account for a higher percentage of the suicide deaths than do the low quartile regions. Here's the gender one is where there were no differences. It's males across the board. When we look at military veterans, this is really interesting. In those high regions, there is statistical significance when compared to both the average and the low quartiles. So that speaks to, if we're going to focus on places like Jackson County, maybe we need to be spending some of our focus on the vets in those communities, because we know that there's some significance there when we talk about deaths. Race and ethnicity, again, for the high counties, it's the white non-Hispanic deaths that account for a higher percentage of the total deaths. The manner of death, this seems to me at least intuitive, that in those high quartile regions, firearm deaths account for a higher percentage, and in those high quartile areas, all other weapons are lower than the average in the low regions. So again, as we think about prevention approaches and how we can target those approaches, this is the kind of information that is really helpful for us, and we didn't have this information prior to having access to the violent death reporting system. So it's helpful. So any questions about the death data? I know that was a lot of stuff.
Well, Jarrod, you kind of made an argument that we should be looking at numbers rather than rates.
I didn't intend to make that argument that we should be looking at numbers rather than rates.
You didn't mean to?
I did not mean to. My argument would be that we need to look at both.
Okay.
Because the rate paints the better picture. It's the more accurate picture of who's impacted. But I think the numbers are important as well, just because, as I mentioned about how we target our efforts, and knowing where the majority of people die is important as well.
That set aside the correlation between rate and other factors. I'm interested in seeing those.
Yeah, and so we could do the exact same thing with the rates rather than the numbers. I just don't have those slides with me.
I think maybe I displayed my bias.
Fair enough.
In Colorado, how many undetermined deaths do we have that could be suicides? Do you know?
How many undetermineds that could be suicides? We don't know. The suggestion is that we're getting better at calling suicides and not accidents or something else. But there's always that argument around, well, what about a one-person car crash where no suicide note is left? That's going to be called a car crash almost all the time, unless someone in the family knew that person had told someone that I'm going to kill myself and here's how I'm going to do it. So there's a little bit of missed data there, but I would argue that our coroners are much better trained now and more receptive to calling the deaths as they are.
And are they consistent, you think, county to county?
No, I don't think so. I don't think the coroners are consistent. Our coroner system is a unique one in that there's no requirements to be a coroner, in my understanding, other than you live in the county and you're 18 years old. So I do think I might run for coroner, but I have no qualifications to do so. Eric.
One of the theories about Colorado's high rate of suicide, which I've never seen really analyzed or looked at, is the fact that so many of us are here without extended family, without that support beyond our immediate family.
Mm-hmm.
So, I don't know, 2.5 million of the 5 million of us are probably immigrants into the state, so we don't have the grandparents, the aunts and uncles. Is there anything in the data that's available that can be drilled down to look at that? That would be certainly one way to help this.
It's part of the theory, so we know that social isolation is a risk factor for suicide, but it's not one of the things that we try to capture in the violent death reporting system. But it would be, I think it's capturable when you're interviewing family members or people who are left behind about circumstances, but I don't think that's something that we capture now. It would be a fascinating study, though, for budding students. So unfortunately, at the national level, our most recent year of data is 2010. So we just don't know. My assumption is that we'll see the same trend. Just because of historically where Colorado sits, I just assume we'll be in the top 10 still. But it's not going to put us at number 1 or number 2, I would imagine, by 2012. So it's just my assumption, but we won't know for a couple of years. Yeah.
In terms of you're talking about making decisions with limited resources, targeting your resources, to what extent does local community interest factor into that? Because you can analyze a bunch of statistics and determine where you think the need might be.
So, that's a great question. I don't know that I've set this up perfectly, but when, for example, the community grants that I give out, that's an opportunity for communities to apply for funding, state funding, and I try to leave it open for them to target the populations that they see as the most important, but they also have to back that up by the data. So, oftentimes you'll get grant applications that say, we're going to do this school-based intervention effort, but they can't back it up by the data. And so it's just part of the requirements. And certainly, local input is, as a state employee, that's one of my, I hope that I never go into a community and tell them what they should be doing, but get input. And from a public health perspective, at least in the prevention services division where I work, that's a point of emphasis for us, is to make sure that, one, communities are ready to implement the work, and that they identify the needs in partnership with us. Yeah, great question. All right, so let's talk about suicide attempt data briefly, because the numbers are much higher than suicide deaths. And when you look at suicide attempts, the data all just switches. Females attempt suicide about 2 to 1 versus males, and our highest suicide attempt rates are among our adolescent females. And so this is just 3 years of data, and when you just look at the numbers, the raw numbers of suicide attempts, there are far more hospitalizations for suicide attempts than there are suicide deaths. And this is just a fraction of the suicide attempts, because this table only shows those suicide attempts that are severe enough that that the injury requires hospitalization. This data, until 2011, we did not have emergency department data. We certainly still don't have clinic level data. We have self-report data, but there's also all those suicide attempts that don't ever get seen by an emergency department or a hospital. So these are only the most severe suicide attempts on this particular slide, but still, even with that, adolescent females have by far the highest suicide attempt rate for hospitalization. So this is a slide that was just created for me, and it's a little messy, but I use it because it shows us a glimpse of what the emergency department data that we just started collecting on a statewide level from emergency departments, and we don't even have the 2012 data ready yet. But looking just at that first year of 2011, it's interesting to look at the means and the sex and how the suicide attempt is presented, or what the method is. And so the discrepancy between emergency department and hospitalization versus deaths is considerable. So most hospitalizations are overdoses and cuts. And again, the theory is that those are attempts that are much more survivable. So if you can get someone to help, during the process of an overdose, the likelihood is that they can survive. And then, of course, we have this whole other data set about self-report data. And I think this is fascinating because, so are people familiar with Healthy Kids Colorado? It's weighted data, and at least in 2011, the data are weighted, so it's representative. and they ask a series of questions about health indicators, and some of those are about mental health and about suicide. And so what these data show is almost a quarter of students have indicators of depression in the previous 12 months. 15% or so have considered suicide in the previous 12 months, and 6% of the respondents have suggested that they have attempted suicide in the previous 12 months. So when if you were to calculate that based on the percentage of 9th through 12th graders in the state of Colorado, and if you take 6% of that total, that's a far larger number than this slide. And that's just for 1 year. This is for 3 years. And so obviously that number's somewhere in the middle. But it kind of illustrates that the data aren't perfect, because we have self-report data, hospitalization data where there are gaps, emergency department data. We miss a lot of data. But it's what we have to work with, and it can inform the work that we do. So I would never suggest either that doing youth suicide or school-based suicide prevention work is not important, but maybe the type of prevention and intervention work that we implement at the school level can be influenced by this. And so building resiliency skills, teaching protective factors, increasing connectedness, rather than necessarily always focusing on the risk side of things. How do you build the tools in adolescence so that when they reach that higher risk age group in the working age populations, perhaps those tools are in place? And so I think we've established some of that in Colorado and in the U.S. because of the funding that's been available historically, which is promising. Okay, let me briefly, since we've been asking questions throughout, should I just keep going or should I cut myself off? Keep going? You can cut me off too if you want to. That happens all the time. So at the state health department level, and these are just a few projects that I think are interesting. We have what we call Colorado's 10 winnable battles. The CDC did a winnable battles project. Governor Hickenlooper charged the Department of Public Health and Environment to identify our 10 winnable battles. And what you see in there is that mental health and substance abuse is one of our winnable battles. And in fact, it's one of 3 that the governor has identified to work on over the next 3 to 5 years. And so the mental health and substance abuse winnable battle team is in the branch that I work in at the health department. My boss is the champion for the substance abuse mental health winnable battle. And so we are trying to work with other state agencies and other partners to prioritize the public health work that we do around mental health and substance abuse, which requires us to work with the Division of Behavioral Health, Department of Human Services, Healthcare Policy and Financing, and other state agencies to rally around priorities to help improve mental health and substance abuse. And I think this isn't a direct result of this winnable battle, but we've seen it last year, and it will begin to be implemented soon, is that we just allotted $20 million to go towards mental health crisis services in the state of Colorado. And that is huge money, relatively speaking, for the mental health and substance abuse community. And all that stuff will start rolling out soon. A House bill passed in 2012 called House Bill 1140. It was an unfunded mandate to my office, so there was no fiscal note attached to it. But what it does is requires my office to work with all of the hospitals in Colorado, well, all of the licensed short-term, critical access, and licensed general hospitals, to provide those facilities with information about suicide prevention and resources in the communities with the intent to be provided to individuals and families at the time of discharge, because there's no standardized protocol around what hospitals are required to provide when it comes to suicide prevention. The law got revised, so it is not a requirement of the hospitals. The language says hospitals may use the materials. So it's, I have to do the work, but they don't have to use the materials that we've provided. And so what we also decided to do was do an assessment of the hospitals, just to get a sense of what are you providing now, what training needs do you have, what's missing, what's your current protocol. And so we just recently finished that assessment in partnership with the Colorado Hospital Association. We got a 65% response rate, which we wanted 75%, but for our first year, our initial response rate was 23% or 19% or something like that. And so I called the hospital association. I'm like, you don't want this to be the case, do you? And so they were very gracious in making personal calls to hospitals. And we have some really interesting information from that. So moving forward, we can do more targeted recommendations. So one of the questions we asked is, what training needs do you have for your hospital staff around suicide prevention and intervention? And we listed some potential training needs, and all of the response was pretty considerable that yes, we need and want training around suicide and suicide prevention and intervention. And so that to me suggests, well, let's provide them with some options for training. And maybe at some point down the road, the legislature will decide to fund this and we can provide hospitals with training and actually pay for it. So it's movement like that even though this is a bill that really was meaningless because there was no mandate, it could move into something that is meaningful down the road if we do it right. Have people seen Man Therapy? It's my favorite project, so I'll talk about it just a little bit. Which my researcher friends in the room love it because we haven't evaluated it yet. Anybody wants to evaluate it, I am open for business. If you bring some money, I'll bring some money. We'll meet right in the middle. It'll be super. But we looked at the data. We know men die by suicide the most. We know it's in that working age group. We know that historically, we have never done anything specifically targeting the working age male population. The data tells us that men, while there's no evidence to show that men have lower rates of depression than women, they access professional services way, way less than females do. And so we decided we want to try to close that gap. How do we reach men who we call them double jeopardy men who exhibit the highest risk factors for suicide, and they combine that by being the least likely to access mental health services? How do we engage that group? So I partnered with a nonprofit here in Denver called the Carson J. Spencer Foundation and an advertising agency in Denver called Cactus, and we created mantherapy.org, and it's like a 5 or 6 year project. We launched a website last July, and the website, here are the goals, are to do some social norming, to create some social change, to empower men to take ownership of their wellness, so to seek help when they need it. And our long-term goal, this started as a suicide prevention project, we think it's become more of a mental wellness project for males, is to reduce suicidal thoughts and deaths among men, but that's very much a long-term goal. To do that, we chose to use humor to engage men. And so that's the crux of the website. That was a pretty big risk for us. I mean, in the suicide prevention community, that's not something that we have done ever before anywhere. And we've had some pretty good success for that. And so this is the website. If you haven't checked it out, you should just take 10 minutes and go check it out. It's really interesting. It's a video-driven, flash-driven website. We hired an actor who plays Dr. Rich Mahogany, who walks you through the website. And the website's not just about suicide and depression, it's also about anger and anxiety and substance use, because we know that men show up at their doctor not saying, I'm depressed. They show up saying things like, I'm pissed off all the time, I can't sleep, I'm stressed out. That's how they show up. And so getting males to recognize, oh, that might be an indicator of depression, and here are some things I can actually do to address that. And our goal is to create a menu of options. Obviously, if somebody has a brain disorder, the recommendation is you have to go see a professional. But if we reach men prior to that who are just struggling a little bit, we want to give them some opportunities to dabble in their mental health without saying you just have to go see a professional. So we've tried to create a variety of options for guys to start to engage in their mental health. And to get people to the website, we just created a bunch of really, funny, some controversial talking points. From a state public health perspective, there's no way I could have done this on my own because it never would have gotten approved to push the envelope like we have with some of this stuff. So check it out. Moving forward, we are partnering with Children's Hospital and Carroll and the Piper Group and the School of Public Health and the Harvard Injury Control Research Center to pilot a means restriction education program in the Children's Hospital Psychiatric Emergency Department. And so it hasn't started yet, but it will start any moment. We're totally ready to go. It's an adaptation of a training that it's called Counseling on Access to Lethal Means. And what Children's is going to do is train all of their social workers and mental health providers on how to talk to parents or legal guardians about lethal means in the home, and to give them tools for removing firearms and restricting access to lethal medications. And there's some research behind means restriction education that shows that it's effective. We know that post hospital discharge or ED discharge is one of the highest risk times for suicide death. And so providing them with tools to make their loved ones safe is a critical approach. And then finally, working in, Dr. Allen from the Depression Center has led this charge of creating this convening for Colorado. And what that's really about is bringing new partners to the table outside of just the suicide prevention and mental health community to really focus on how do we move to the next step. How do we reverse this upward trend? And from our perspective is we need new people at the table. Not just new experts, but new dollars, business, educators. I mean, we're trying to bring everybody to the table who might have a stake in this game. And the emphasis is to focus on some priorities so that we, as a state, regardless of the work that we do, to focus our efforts on some specific priorities over the next 3 to 5 years. And whatever priority we land on will be based on the recent national strategy for suicide prevention. So we're trying to model the national strategy, and we're trying to identify some priorities, expand partnerships, and begin to implement those priorities. And those priorities are going to be things that we know are most effective and that we're most ready to implement in Colorado. And so that's moving over the next year or two, which is really exciting. So I think that's where I end my talk. A couple of minutes for additional questions or comments. Yeah.
Since you have a lot of information on residents, and I was wondering, have you been able to link them to intervention programs, maybe at the county level, and be able to see which interventions might be most effective, or talk a little bit about interventions?
I'm not totally sure I'm understanding your question. My apologies.
I mean, we have this trend there.
Uh-huh.
At a pretty detailed level. And so if there are differences across different regions in terms of the kinds of interventions that we have to be relevant data to
Yeah, so I'd say we haven't done that in the past. Yeah, so have we looked at targeting interventions based on the trend data and the location where people...
Or if there are pre-existing, if there are intervention programs that do not have any specific areas, then if there are different types of areas, you can identify which programs.
Yeah, so trying to identify what programs work with specific demographics and groups, kind of the gist. So I'd say, no, we haven't done that well to this point. I think that's where we're trying to move. That's the direction we're trying to go in. But it's, and suicide prevention is a relatively speaking, a very new science and a new movement. So there's so much research that still needs to be done. As far as best practices and what to implement, there aren't very many best practice programs in suicide prevention. So it speaks to the need to identify which are, and also to better evaluate the stuff we're currently implementing. So we're moving in that direction, but I don't think we're there yet. Carolyn.
I just wanted to follow on. We did do an evaluation about maybe 5 to 6 years ago, looking at county level services related to mental health and different types of services in relation to suicide risk for people who've been hospitalized for attempts. And I'm happy to send that. There was a relationship between the availability of different types of mental health services and suicide risk.
Yeah, and where we're at now, particularly with the mental health services, is with that new $20 million, the theory around that approach is that needs to be and will be statewide. It's not going to happen overnight, but there's some momentum towards that. And from the suicide prevention and public health perspective, I think we do really great work in pockets, but there's nothing that we do that's statewide. Yeah. So I know we're at our time.
We have time for one more question.
And I'm happy to hang out if people have questions.
If you didn't sign the sign-in sheet, I think it went around and then some more people filled in. Please do that so that we know the count of people who were here, and also we'll send you announcements of future seminars. But I'd like to thank Jarrod for coming over today and giving a talk.
Yeah, thanks for having me.